Hey everyone, welcome back to the channel. In today's video, we will be going through another set of high-yield USMLE questions in obstetrics and gynecology. So let's get started. A 25-year-old Gravida 1 Para 1 woman is evaluated in the postpartum ward one day after an uncomplicated vaginal delivery. She received epidural anesthesia during labor and has since noticed frequent dribbling of small amounts of urine without a strong urge to void. A bladder scan reveals a post-void residual volume of 350 ml. Which of the following is the most likely diagnosis? A. Detrusor instability. B. Interstitial cystitis. C. Stress incontinence. D. Urinary fistula. E. Overflow incontinence. The correct option here would be E. Overflow incontinence. A post-void residual volume of more than 200 ml indicates an inadequate emptying of the bladder. Now, in this patient, the post-void residual volume is elevated and it is 350 ml, which is a classic indicator of overflow incontinence. The overflow incontinence occurs when the bladder is unable to empty completely due to detrusor hypotonia or detrusor areflexia, which is the loss of bladder muscle reflexes. The most likely cause of this in this postpartum patient is the epidural anesthesia, which can temporarily affect bladder tone and sensation, leading to an inability to fully empty the bladder, and as a result, urine leaks out in small amounts due to the overdistension of the bladder. Let's have a look at why the other options are incorrect. Option A, detrusor instability, which is also known as overactive bladder. When patients they have this condition, they present with a sudden strong urge to urinate, followed by involuntary loss of urine. Option B, interstitial cystitis, which is characterized by inflammation of the bladder wall and leads to painful urination and frequent small volume voids. However, incontinence is not a typical feature of interstitial cystitis, and additionally, patients with interstitial cystitis may have urgency. Option C, stress incontinence. So stress incontinence occurs when urine leaks out due to increased intra-abdominal pressure, such as when somebody is coughing, sneezing, or laughing. This patient does not report these typical triggers. Also, the stress incontinence does not usually result in an elevated post-void residual volume. Rather, patients may have a normal voiding but difficulty holding urine during activities that increase intra-abdominal pressure. And option D, urinary fistula. So a urinary fistula is an abnormal connection between the urinary tract and another organ like the vagina. It results in continuous urine leakage and not the intermittent small amounts seen in the overflow incontinence. Additionally, patients with a urinary fistula typically have a normal post-void residual volume since the urine leaks continuously due to the fistula bypassing the normal continence mechanism. Let's have a look at the second question. A 25-year-old woman is referred by her family physician to a gynecologist for evaluation of intermittent lower right abdominal pain and irregular menstrual cycles. Over the past 2 months, she has experienced occasional sharp pain in the right lower quadrant, and her periods have become irregular in both duration and flow. Physical examination is unremarkable. A transvaginal ultrasound reveals a 6 centimeter right simple ovarian cyst. She's prescribed oral contraceptive pills to help regulate her menstrual cycle. What potential complication is she at higher risk for? A. Endometriosis. B. Ovarian torsion. C. Pelvic inflammatory disease. D. Ectopic pregnancy. E. Ovarian cancer. The correct option here is B. Ovarian torsion. Now, ovarian torsion happens when the ovary twists on its vascular pedicle, cutting off its own blood supply. The risk of torsion increases with ovarian cysts, especially the larger ones like the one seen in our patient. And the reason is that because when ovaries become heavier with a cyst, they're more likely to move and twist around themselves. Also, another additional point is that the right-sided torsion is more common because the right utero-ovarian ligament is longer and the left ovary is partially stabilized by the presence of the sigmoid colon, which limits its movement and reduces the likelihood of the torsion. Let's have a look at why the other options are incorrect. Option A, endometriosis. Now, endometriosis is caused by endometrial-like tissue growing outside the uterus. Having a simple cyst, like the one the patient has in this scenario, does not increase the risk of developing endometriosis, although endometriosis itself can cause ovarian cysts such as endometriomas or chocolate cysts. And the risk factors for developing endometriosis include having a family history, early menstruation, short cycles, heavy periods, and never having children. Option C, pelvic inflammatory disease. The risk factors, they include having multiple sexual partners and sexually transmitted infections such as chlamydia or gonorrhea. Option D, ectopic pregnancy. Now, an ectopic pregnancy occurs when a fertilized egg implants outside the uterus, most commonly in the fallopian tube. Ovarian cysts do not increase the risk of ectopic pregnancy, and the risk factors for developing ectopic pregnancy are having certain sexually transmitted infections which lead to pelvic inflammatory disease and previous tubal surgeries and previous ectopic pregnancy. Option E, ovarian cancer. Now, ovarian cancer is far more common in postmenopausal women, typically in their 50s or 60s. Having a simple functional ovarian cyst like the one in our patient, it occurs in younger menstruating women and are usually benign. The risk factors for developing ovarian cancer are increasing age, that's why it's more common in middle-aged or older women, and having a family history or genetic mutations like BRCA1, BRCA2, or Lynch syndrome, and having a history of certain cancers. This marks today's set of questions. Thank you for watching.